Okay, it's my pleasure to present Dr. Veronica Irene Yuel, practicing in Raipur. She did a postdoctoral fellowship in reproductive medicine from Bangalore, Assisted Conception Center, Bangalore. She presented original work as first author and has published nearly 20 papers in reputed national and indexed medical journal in the field of assisted reproduction, obstetric, and gynecology as first author. Dr. Veronica Irene Yuel will present for us a very interesting talk about the quantitative assessment of follicle size on OOCYTE developmental competence. It's up to you, Miss.
Thank you, respected chairpersons. At the outset, I would like to thank the organizers for giving me an opportunity to put up this topic in front of you guys. I would speak on quantitative assessment of follicle size on OOCYTE developmental competence. Now, controlled ovarian hyperstimulation is critical to assisted reproduction in the sense that we have to increase the number of oocytes undergoing development, and only a portion of these will be competent for fertilization and develop into viable embryos. Hence, the process of selection, follicular growth, and ovulation has guided the development of this IVF treatment. In this treatment, we have to override the selection of a single dominant follicle, thus driving multiple follicles, multiple antral follicles into the growth phase. Now, this theory is based on an assumption that the follicular size predicts the developmental competence of the oocytes. Several human studies and a few animal studies form the basis of this assumption. Oocytes derived from larger follicles, they outperform those from smaller follicles in terms of fertilization and embryo quality. So let us have a look at the evidence. What does the evidence say? There have been many studies that have suggested decreased fertilization rate and embryo quality observed with oocytes originating from smaller follicles, but this can, however, be overcome with ICSI. Majority of the studies say, although the oocyte quality is lesser in the smaller follicles, but with the revolution of ICSI, we are able to overcome and develop good embryos. Once we have got enough good embryos, for pregnancy and implantation is not a problem. However, there are some authors who have suggested normal fertilization of an oocyte is independent of its follicular size origin. There are reasons for questioning various laboratory outcomes that result from the ovarian hyperstimulation and IVF procedures, although there is evidence to suggest that follicle size can influence the outcomes, the odds of oocyte maturation, fertilization, and the resultant embryo quality from oocytes originating from a range of follicular sizes, with comparisons with the lead follicular group need to be elucidated. This helps us to elucidate the relationship between developmental competence of the oocyte and the follicular size, whether the follicular size was an independent predictor of the fertilization rate, nuclear maturation, polyspermy, or embryo quality. So let us consider each point separately. Coming to oocyte nuclear maturation. Michel et al. In 2008, their study has shown that the odds of oocyte maturation was statistically significantly decreased with smaller follicles. These authors hypothesized that an oocyte developmental competence depends on the growth of the follicle and its intrafollicular milieu. Therefore, competence was expected to be superior in the lead follicular group. Fertilization. The same authors have also found that the 2PN rate is higher it is highest for the M2 oocytes derived from the lead follicular group. Also, there was a decrease in the fertilization rate noted in their study noted in another study by Hector et al., where they said that there was a decrease in the fertilization rate as the follicular size decreased. Coming to polyspermy, abnormal fertilization can be considered as a marker of oocyte competence. Evidence that oocytes obtained from follicles less than 12 mm, the odds of polyspermy are over twofold higher than that for larger follicles. However, Michel et al. Have further suggested that although the rate of fertilization is less with oocytes that originate from follicles that contain less than 1 ml of follicular fluid, that means the follicle at that time will be less than 12 mm. But if they fertilize, the 2PN rate, that is fertilization, would be the same. Embryo quality. The process of IVF may result in pronounced embryo heterogeneity in terms of morphology of the embryos. There are reasons which are unknown for this, but probably the developmental capacity of the oocyte is the one that is affecting the embryo quality, and studies evaluating whether embryo quality was associated with oocytes' follicular origins are conflicting. Berg et al. Suggested that embryos created from oocytes originating from smaller follicles, that is less than 12 mm, they experienced less cleavage. They did this study in 1998. Others found no difference in cleavage rates of embryos derived from oocytes aspirated from follicles greater than or less than 16 mm. So coming to cell number fragmentation, day 3 cell numbers and embryo fragmentation are important predictors of implantation. Studies suggest that the average cell number of embryos is the same regardless of the follicle size. However, Michel et al. In 2008 showed that embryos created from oocytes from the lead follicular group have on an average statistically significant less fragmentation. Therefore, the wide range in embryo fragmentation from the smaller follicular sizes suggests that good quality embryos can be derived from oocytes originating from smaller follicle sizes, albeit at a lesser frequency than from a larger follicular group. Coming to implantation, there was no assessment of implantation related to follicular size of origin. Not many studies have been done. Therefore, Michel pointed out that decision regarding embryos selected for transfer based solely on embryo morphology and not on follicular origin, which could have been obtained from oocytes originating from different follicles. Now, once we have embryos originating either from a smaller follicle or from a bigger, does not make a difference. If we have got enough good embryos after ICSI, implantation would not be a. However, many studies have not been done, yet there was not enough data. When I did literature search on this topic, enough data was not available. Very few studies were available on this point. Therefore, to conclude, the lead follicular group most likely to have a mature oocyte capable of fertilization and the one best suited for development into a high-quality embryo in vitro. Nuclear maturity, fertilization, and development into embryos from oocytes from smaller follicles is lesser than that of the lead follicular group. More studies are needed to pave the way to derive decision-making models based on a follicle size to optimize outcomes from ovarian stimulation. Thank you.